Lovely. Management of fetal pleural effusions. I think the diagnosis, I think, will keep it very, very simple. There is only one differential. What's that? Cardiac, yeah. Pericardial effusion. Yeah, pericardial effusion. Fabulous. It's a pericardial effusion, okay? So that's the only differential you need to worry about. It's gone mad. Okay, so here you can see the lungs are pushed posteriorly, and this is an extremely large pericardial effusion. I think Jelani Carvalho, she's speaking tomorrow, yeah, has reported on a series of these that we've seen, and almost always these kind of large pericardial effusions in early pregnancy are associated with ventricular wall defects and little aneurysms. So if you look carefully enough, you'll see an aneurysm which is causing a kind of significant pericardial effusion which is pushing these babies back. Most of them we've managed conservatively and had very good outcomes. And in one case, we had to do a drainage because the baby was going into heart failure. This, however, is a fairly straightforward. Yeah, so the lungs should not be pushed backwards. They should be squashed towards the heart with the bilateral pleural effusions. So fluid in the pleural space, it is not much of a diagnostic problem. It's relatively rare with a 1 in 15,000. Traditionally, aneuploidies have been reported in 10% of these cases. But this is traditional data from over 10 years ago. It's almost certain now, with the advent of combined screening, that the vast majority of these aneuploid babies, and typically trisomy 21, have been screened out prenatally at 11 weeks. And therefore, nowadays, we see euploid, normal babies with pleural effusions. Its associated malformations are present in about 25% of cases. This talk is not going to deal with pleural effusions with associated malformations. Yes? We've already dealt with pleural effusion associated malformation of CCAM, but if, for example, it's part of a genetic syndrome or part of multiple fetal abnormalities, then that has to be dealt with according to the particular diagnosis made. And we can't go through every one. But what we can do is say, okay, you've got an isolated pleural effusion. What do we do then? The implication is that we're dealing usually with a congenital chylothorax, which is a delay in the development of the lymph drainage of the lungs, resulting in lymph accumulation either unilaterally or bilaterally. Is that okay? I'm sorry if I disappoint you, and I'm not going to go through the 15 different reasons for pleural effusions and how management should change. But the key here is that we're going to be dealing with pleural effusions and not, a genetic syndrome that's going to have a pericardial effusion or pleural effusions as a consequence of Rhesus disease and fetal anemia, because it's implicit that you treat the fetal anemia and the baby will recover from its eye drops. The pleural effusion, there is a theoretical risk of pulmonary hyperplasia. I say theoretical because it persistently appears and crops up in the literature. But I'm pretty confident that the vast majority of times when babies die because of pleural effusions, it's not because of pulmonary hyperplasia, but it's because the babies develop eye drops. It's rare that these babies actually will die of pulmonary hyperplasia. Yeah, this always looks dramatic, but as the pregnancy goes along, if this is a survivor and it's a congenital chylothorax, the fluid gets less, and as the baby takes its first breath in, this lung expands some more, and it's often very hard to spot a pleural effusion postnatally. Far more important is the compression of the heart and obstruction of the venous return leading to eye drops, and the compression of the esophagus leading to polyhydramnios. And the combination or the isolated appearance of these two, i.e. preterm delivery and fetal hydrops fetalis, the combination of the single occurrence is the main risk for these babies. The spectrum of congenital chylothorax is wide, going from isolated pleural effusion here, unilateral, to a bilateral pleural effusion, developing eye drops, to a grossly edematous baby with little or no lung on one side, agenesis, and a small lung on the other. Congenital chylothorax per se, which is what this talk is mainly about, is abnormality of the lymphatic drainage system. There is usually spontaneous resolution. The key is the congenital chylothorax going to kill the baby before the resolution occurs? And that's the problem we have. Neonatally, no treatment is required. It's usually supportive treatment. However, surgery or other treatments are used if it's unresolved. The key thing to remember here is that there is a relatively high association of congenital chylothorax or isolated pleural effusions with or without hydrops with the diagnosis of Noonan syndrome. So the management, this is relatively straightforward. This has been reviewed recently in 2 large series. The issue here is that survival of pleural effusion in the absence of hydrops is near 95 to 98%. So there is little or no reason to consider any kind of antenatal treatment for isolated pleural effusion in the absence of fetal hydrops. So the issue is antenatal treatment is only required under these conditions, and single thoracocentesis, 13 reports with a 54% survival. Multiple thoracocentesis, 67% survival, i.e. 12 out of 18, and by far the commonest management strategy is thoracoamniotic shunting, which is a 63% survival. So we turn, in the presence of fetal hydrops, a survival rate of 5 or 10% for fetal hydrops, you can increase it to 50%, 67% or 63%. So one could argue initially, just looking at this data, well, why do we need to do thoracoamniotic shunting when it is apparent that hydrothorax and hydrops has an equivalent survival for these 2 groups? What's the answer? Don't know? You all shunt or you all thoracocentesis? Don't know. Okay. Actually, if you look at it, as I said, there's no significant difference between treatments. The problem we have is the publication bias, i.e. there may be cases, because these are only successfully treated cases that are published. There may be lots of cases that are treated where the baby dies. The problem we have is that with a single thoracocentesis, there's reaccumulation of fluid within 2 days. So if you decide to manage a baby that presents at 22 or 24 or 25 weeks with hydrops as a consequence of pleural effusion, you are going to need to do weekly thoracocentesis for the whole of the pregnancy. Yes? Because reaccumulation of fluid is rather rapid. Whereas if you decide or you diagnose hydrops developing in a baby that you've been following for several weeks, and at 32 or 34 weeks you think that hydrops are developing, then management by thoracocentesis, single or multiple, would be appropriate because you may only need to do it once or twice, and it's technically, for sure, a lot simpler. So the strategy is early hydrops with pleural effusion should certainly have fetal shunting as its mainstay of treatment. But if you think that a case that you've been following up is just going to develop hydrops or developing hydrops in late pregnancy, then a multiple thoracocentesis approach may be much simpler to do. Quite often, shunting late babies can be extremely difficult. Thoracocentesis, just putting a needle in is straightforward here. I think there is 2 groups. I'm in the smaller group. Most people tend to use a kind of old-style Rodex shunt, which is a reusable handmade shunt with a very, very blunt tip. Yeah, it's not sharp. It's very hard to put in. And those of you who've struggled with it will know that it's quite hard to get into the chest. Others use this, which is the Harrison Bladder stent. It's extremely sharp. It's a cutting tip needle. It goes through very, very easily. And the second thing is this is an extremely powerful, very easy to insert shunt. The Rodex shunt and the specifically designed shunts that are made are very, very tough, very hard, and incredibly hard to put in to the shunt tubing. So the comparison is technically this is far more straightforward. The problem you're going to have is you're going to say, well, if I put this in, surely this is so soft and so thin that the baby's going to block it. Yes? That it's going to squash it. Actually, no, it doesn't. Because all this is you're not putting this in to sit as a tube through which the fluid will drain. You're putting this in to create a permanent fistula between the pleural cavity and the skin. So all you're doing is you're putting in a stent, a solid piece that's going to sit there and allow that track, that cavity, that hole you made with a 16-gauge needle to stay permanently open for the rest of the pregnancy. So you don't put this in to allow fluid to drain. You put it in to keep that hole open. And most of you who've been around and taken these shunts out of delivery will say that whether you use this or whether you use a big shunt, the old Rodex shunt, they're almost always fully blocked with fetal debris, fetal skin debris at delivery. And also, what you'll see is that the fluid leaks from the side and not through the shunt. That's why when you pull the shunt out, you need to use special stickers and special fluid to block it off to stop it creating a pneumothorax. The second issue with shunting is that, and these are the two pigtail shunts here, is that you need to put it around the back of the baby. You have to get used to tipping the baby over with a shunt needle and putting it into the back, because putting shunts into the front, this is the spine, and you can see this is the internal loop, and that's the external loop sitting there next paraspinal. If you don't put it through the back, the babies just pull them out. Yeah, it's irritating. It's very painful and irritating, and they'll just yank them out. So it's not. You might as well do multiple thoracocentesis if you're not going to be able to get it in through the front. So, what are the problems and complications? There's failure and repeat treatments for shunting, and people should be warned about that, and a fetal loss rate, I believe, because of the size of the tubing. There is a significant preterm delivery rate, which is just the alternative for miscarriage, and shunt migration. I suppose if that shunt placement is difficult, then shunt migration is a possibility. This is a theoretical risk which is repeatedly mentioned, but again, as I said, I don't think shunt blockage is a problem, because all shunts block. You just leave it there as a wick. I'm going to finish very quickly with this emerging treatment, pleurodesis. Pleurodesis refers to the introduction of chemical agents into the pleural cavity to cause a chemical reaction and inflammation, and subsequently a fusion of the pleural layers, and to get rid of the hydrothorax. There are OK432, which is a specific agent of blood, and octreotide is a somatostatin analog that inhibits lymph secretion. There are very few cases that have been reported prenatally. And very important, before you do it, you need to understand that if you use this treatment, you are severely handicapping what your pediatric surgeon and what your pediatric colleagues may be able to do postnatally if you are not successful, because you create a chronic inflammatory process within the lung that inhibits their ability to treat the baby afterwards. So, antenatal management, expectant management when hydrops is absent, because we'd expect almost a near 98-99% survival. Drainage of pleural effusions is associated with improved survival in hydrops. Drainage should be thoracocentesis based for late presentations, and thoracic shunting for mid-trimester diagnosis. There is a significant incidence of Noonan syndrome which should not be missed. Thank you.